Thank you very much, Rod, and I'm honored again to be here by SSF and all of the wonderful speakers who are here that have presented. In fact, it's a little unfair. You gave me an unfair topic because the evolution up to this topic was complete in the sense that everybody covered what else you can do beyond screws. So if nothing else, this might be a little devolution back to why screws are still such an important part of robotics, but we'll try to tackle it. So as you know, just starting off, robotics traditionally has been all about the different platforms to achieve one thing, and that is adequate fixation. And each of them have small iterations on how they achieve it, whether it's directly through the use of transferable mobile tracking systems linked to navigation, bed-mounted, floor-mounted, and so on. So there are nuances in terms of their differences, but traditionally it always began with this. And the way it began was that robotics was not this amazing, beautiful, autonomous system on the production line that we've been, enamored with in the last couple of talks. We're standing in looking at the sky. The trajectory is always up. My goal is to bring you down to earth a little bit and tell you what it isn't. So I'm going to flip the script a little bit. Robots are really just cobots right now. They're assistive devices. And for the most part so far, they've really been instrumentation placers. So they've been useful for part of the surgery, but not all of it. And this is all linked to navigation, which is probably the greatest advance with robotics so far. So why do I care about having a spine robot? What is it for me? Why do I need to invest in this amazing amount of cost and perhaps burden to the healthcare system, to my healthcare system to get one? Well, the other speakers touched on it, but they went way past it. I just want to bring you back a little bit, and that is that, of course, it improves the accuracy of your instrumentation. It reduces radiation exposure, and now we have good data that it drops your length of operative time and blood loss. To the surgeon, that's for the patient. To the surgeon, radiation exposure is huge, and that matters because that's part of the longevity of our careers. Ergonomics is incredibly important. I'll touch on that coming up as a major reason as to why it's not just about screw placement, but there's so much more to having a robot. And then there are advantages that come with a learning curve. You saw some in the last presentation, some of the additional things that can be achieved, procedures that can be achieved by understanding how this machine effectively that has 6 degrees of freedom is able to get you to inaccessible areas and place more than just screw instrumentation, but cages and other important aspects of the surgery. And then to the healthcare system, yes, of course, it's a cost hit to begin with, but remember, everything is opportunity cost, right? So what you've lost by cash flow through a capital expense to the robot, you've gained in other ways, the least of which is important is marketing, but the experience for the patient and all of the various benefits that come from that, reputational, psychological, and so on. And so it's got to the point where somebody's advertising that robotic-assisted surgeries made them famous. I would argue that our last few speakers humbly don't admit it, but that's the case. But bringing it to their local environment actually makes them proud. So what are spine robots not? I'm totally taking the opposite tack to Martin. They are not this right now. We do not have multiple different arms that are able to remove lesions, although we'll see some of that in a few slides' time. They're not an exoskeleton that we wear that guides our hand and we're just the assistant to achieve our goals in surgery. This is not what they are. And they are assistive devices. They're not an autonomous robot, and they are not you. They don't have the ability for rapid decision-making and nuanced ideas, especially intraoperatively, where a change in plan needs to be made. So the story of robotics is the story of navigation. I think we've established that by now. The minimum capacity of the robot is to plan a screw trajectory, and we've talked about it, and that's done through acquisition of fluoroscopy, either inside the operation, emerged to a pre-op CT, or beforehand, or an intraoperative CT. And all of this leads us to a few benefits, which we've discussed: that screw accuracy, reduced radiation, and probably, as you're beginning to absorb, improved efficiency. But probably the best benefit of robotics is the fact that we can pre-plan. We can pre-plan and then navigate to execute the plan that we've decided on. And there's plenty of data now, we won't go through it, with respect to the improvement, the dramatic improvement of accuracy from freehand to 2D navigation, to computer-assisted navigation, to now robotic arm-assisted placement of instrumentation. There's data, that was data from 2014, this is data from 2021, where we're getting to 95%, almost complete accuracy of placement of instrumentation. And of course, the big other huge benefit is that of radiation exposure. And whereas that's seen as damaging and injurious to the patient, imagine what the cumulative effect of that is to the surgeon over the course of a career. And that's unfortunately led to the real-time understanding of increased cancer rates. So all of this to say that this is leading to advantages which are other than just screw placement. And the first and the most obvious one is that we can now plan our cages, our inner body cages, and we can do that by planning them ahead of time, by bringing our robotic navigation system into view, better than just computer-assisted navigation, and then executing the plan and superimposing what was achieved over what the plan was. And this is a huge benefit. We can size our implants, we can navigate the disc prep instruments, and then we have the option of removing C-arm altogether, and as was mentioned, not even using lead in achieving all of this. So again, this is achieved either freehand or bringing in the tubular guided system, such as a retractor, into view through navigation into the exact spot over the pre-planned location position of where the implant would go, and then following it up with precise cuts with respect to our facetectomies and osteotomies, again, all pre-planned, all with the benefit of drastically reduced navigation in disc prep and cage placement. And let's look at a case where this is achieved. This was a 69-year-old male presented with progressive left-sided leg pain, degenerative disc disease, neurogenic claudication as well, standing and mobilizing, and has had multiple prior procedures. He was an active patient, and he was otherwise neurologically intact. His spinopelvic parameters, for the most part, were matched, a little bit of difference with PI-LL mismatch, but pelvic tilt was not significant. And on imaging, we see that he is effectively lost lordosis through disc height loss and foraminal height loss at multiple different levels, leading to central stenosis, foraminal stenosis, and then most importantly, the presence of a lesion in the form of a synovial cyst. So what were our goals? I always like to identify the goals that we like to achieve and then see where our enabling tools can take us to achieve them. So we need to restore disc height lordosis, achieve some form of decompression, direct in this case because of the synovial cyst in addition to the indirect, preserve the height and the lordosis that we've achieved through our techniques mentioned, through fixation, and then do all of this minimally invasively and maximize our efficiency. So the screw placement is grayed out because we already know that, but in this case, the decompression indirectly is achieved through robotic navigation by bringing the tubular retractor into view over exactly where the pre-planned position of the cage was, and then directly decompressing by, again, tubular placement, probe placement on exactly where the regions of facet hypertrophy were, so we can guide our drill to that region, and then arthrodesing the facet joints and the dorsal elements. And there was no flip in this case. This was a prone lateral case. and the patient was kept in the same position. To me, this is true single position surgery, beneficial for a natural position of the patient and the surgeon. And then going through the slides, looking at the video of this, I've deliberately gone past the section where the screws are important to show you that this is the pre-planned location of the cages, both AP and lateral. And then after the image acquisition and the merge, which this is using the Excelsius system in doing that, we can then come to the actual placement of the inner body cage. You can see the outline of where the cage was planned to be. There's the guided tubeless system. This was early on in our cases where we had a C-arm to assess our AP placement of the implant. There's our disc prep instruments. There's our rasp going across the disc space. There's the cage being placed by the resident, packed with the relevant graft into a final position to give us this final result. So essentially, these were the steps that were achieved. So then we come to other things that were mentioned briefly, such as bone resection, dorsal lamina structures that are removed. And there's significantly increasing studies that talk about this. And there are additional robotic attachments that are now added onto the arm where precise cuts such as these are able to be made. And when we think about it, not only are we able to make these cuts, but we're able to also integrate them together with a plan to help achieve the decompression and assist with the deformity correction as part of the procedure as well. So the software can actually be integrated with machine learning, artificial intelligence to recognize, for example, what a lamina is, to recognize the surgical pattern of behavior of the surgeon, and then if you couple that with an ultrasonic bone drill, you can achieve the goal that you have at hand to exactly proceed to where the bony lamina resected area is and proceed. So this study looked specifically at a modified Gertzbein-Robin scale, not for screw placement, but actually robotic laminectomy in a series of patients, and found 83%. Grade A, B, and C were defined as less than 1 millimeter of deviation from a plan, B and C, and you see 0% for grade C. This is over 40 patients. And the vast majority being less than 1 millimeter of deviation, which is incredible for a laminectomy. All right, something that some of my colleagues haven't mentioned, that is the marriage of endoscopic surgery with robot. Endoscopic surgery is so popular and surgeon-driven that it's actually achieved its own course at SSF, which I applaud. And imagine that you could couple this with robotics to actually pinpoint the initial placement of your cannula and endoscopically placed instrument such that you don't need multiple x-rays, which it's so interesting to me because endoscopic spine surgery is an advance in MIS surgery, yet in the vast majority of cases, multiple fluoro shots are taken, particularly at the lumbosacral junction to get it in place. So this study by Jin et al. Looked at coupling the robot with endoscopic surgery and found that in the single shot puncture group, they were able to achieve precise position of the working channel compared to fluoroscopy. What about tumor removal? We've talked basically about all of the great things that robotics can do other than screws, but we can now outline the position of a tumor, plan osteotomy cuts, perform a robotically guided biopsy, perform a kyphoplasty, vertebroplasty, and ultimately resect a tumor under navigation guidance. So in this case, this paravertebral schwannoma in this particular paper was entirely able to be removed in retroperitoneal fashion with the addition of robotics. Now, this is not a spine robot. This is a multi-armed Da Vinci, but it's only a matter of time where we're able to do this at different angles using a spine platform robot. The other best part of robotics here is that we can plan. We can plan exactly, and we don't need to look further than our own classification system of where to remove, where a location of a tumor is with respect to its significance, such as our Weinberg, Boreani, Bigiani systems. And we can plan exactly where we need to tackle our cuts to be able to achieve our resection and then our reconstruction. So this is my case. This was a 71-year-old female that presented with an incidental sacral lesion. Initial biopsy was consistent with a chordoma. So we knew that we needed to perform an en-bloc spondylectomy, sacrectomy, and we decided to use robotic planned osteotomy cuts here. And this was us planning the osteotomy cuts on the robot. This is what we achieved in terms of resection of the sacrum with exposure of the back of the rectum, and we were able to preserve the S2 nerve root, which was a significant salvage for bowel and bladder function. And this was the actual resected lesion, all done with osteotomy cuts, perfectly planned preoperatively using robotics. And you can see those cuts there. And this was the post-op image that was able to be achieved. Other indications, difficult to access areas. What about a Bertolotti false joint, false L5S1 joint? You can see what we used. This was all robotically guided with a drill. Other osteotomies for other indications, such as spinal shortening for tethered cord, and so on, all done with robotic planned osteotomies. So in other words, there's advantages, much more advantages than just screws. And one thing that I want to end on is ergonomics. We're able now to improve our own health and ergonomic placement. We can add CT angiography, for example, with SI fusion. That is a great robotic procedure by understanding the position of the superior gluteal artery, which is a major vascular incident or injury that could occur during an MIS procedure. And what's next on the horizon? Well, it's really these things: augmented reality, merging our MRI and CT for plexus detection, performing rod bending, automatic segmentation that we talked about using bone drilling, better workaround for posterior cervical, and marrying all of these with AI. And I won't go into it in great detail, but there is increasing data that the marriage of something like augmented reality and robotics can actually achieve significantly more. Marriage of CT and MRI, use of bone MRI that can be uploaded to a robot and then utilized for osteotomy cut. A rod bending that can not be done just preoperatively, but intraoperatively, again, based on the plans that were executed and then achieved intraoperatively. And then, of course, ultimately, the software and the hardware will come together where the robot will auto-plan. It will recognize where the lamina is, recognize no-fly zones, and then put its true robotic nature to work. That's all in the future. At the very least, for me, it's improved my OR efficiency and outcomes. Thank you very much.
Nice job. Very cool, Noosh. Appreciate you not hitting the high spots of the other authors and presenters. Radiation exposure is a big deal.
Talk to us about the cumulative radiation exposure of patients. If you look at everything together.
Fiduciary CTs, 1 millimeter cuts, intraoperative imaging where the surgeons are now hiding in cool cubbies. That's kind of very nice. But do patients actually end up with a bigger radiation burden? If you look at the entire cumulative setup of all imaging required to have high resolution navigation and surgical experience.
I love that question. I think that's such a good point to make. Here's my pushback to that. When, in most cases, patients obtain a preoperative CT scan, and then with computer-assisted navigation, another spin is done in the OR. So you have double the amount of radiation, and ultimately screws are placed based on that. With robotics, with some of these workflows, you're able to acquire the one, as you said, fine-cut CT scan, typically 1 millimeter, and then that's the only CT scan that's achieved. And intraoperatively, a merge of the just 2 shots, theoretically, of an AP and a lateral can be done with the CT. So I would actually argue that there's the potential of less radiation with robotics because one CT is done. compared to 2 or more. And it's fascinating to think about it. Definitely for the staff and the surgeons, where their longevity of practice, it's a huge reduction. I think in terms of not exposing yourself to all that radiation, to the point where you can just stand 6 feet back from a fluoroscope and take the AP and lateral, do the merge, and not need lead for the rest of the case.
Great. Thanks, Noosh.
Thank you.
Appreciate it.